Guys and all the guys, seniors, all my PG students, and first of all I must thank the organizing committee for inviting me as a speaker. So for the PG CME. So my topic is highlights of the changes of ICD-11, ICD-10 and the DSM-5 on personality disorder. So I'll speak mainly on the personality disorder. Actually, but in 3, they contain actually 11 personality disorders right there, and self-defeating personal disorder and the sadistic personal disorders were included in DSM-3R. That when we started our postgraduate degree, that is a PG. And some criteria were there, but all are the categorical type of things. In ICD-10 again, it does not include a separate axis, but other specific personality disorder was included in ICD-10. And 11 I will talk later on. So if you now compare the ICD-9, 10, DSM-3R, 4 and 5, so in 9, but it was dropped out from 10, and it was other specific PGs were included in 10. Passive aggressive, schizotypal, narcissistic, they were included in DSM-3R, but again, those passive aggressive was dropped in DSM-4, but schizotypal, narcissistic, they persisted. Even in DSM-5 also, it persisted. Here the DSM-5, I am talking about a section 2, that is what is used as used, not the research one. That we will talk about later on. So the general definition of personal disorder, if you see, as in DSM-5, it is the enduring pattern of experience and the behavior that deviates from the expectation. That is as usual, that is what we know. It's pervasive and it is inflexible as from the adolescent to adulthood, stable over time, and it has it leads to a distress or impairment. And in PD's, in DSM, they have been included into 2 sections, section 2 and section 3. In section 2, that is what is there, that is for the practical point of view, but in DSM section 3, it is the alternative model. It is the alternative model of personal disorder, and that is the dimensional model. But that is only for research purpose, they have added. But maybe that in long run, the section 2 will be replaced by your section 3, that is the alternative model of the dimensional model, that the ICD-11 has emphasized or given a paradigm changes in ICD-11. That we will talk about in the next slides. So, that is why they have given section 2 and section 3, but section 2 is the clinical that we are practicing, and section 3 only for the research purpose. So in DSM-5, like the DSM-4 and DSM-3, they has taken that I said already categorical approach, whereas they have given the alternative model. ICD-9 also takes the categorical approach. So on that basis, as I said, it is yes or no, that some categories are there. If it is present, you categorize them under that category. So if you see what are the DSM-5 sections that include now, that is in section 2, this paranoid, schizoid, but those which you see that is your red color, those are not included in ICD-10 actually. So see, those personality changes due to other medical conditions is there in DSM-5, borderline schizotypal, and these are there in the DSM-5, narcissistic is there, but in ICD-10 these are not there, but borderline is there, but they have been classified as your emotionally unstable personality disorder. That is the difference. So terminology is different. There were 12, but here in ICD-10 it is 10. So in DSM-5 section 2, here the groups under cluster A, B, C, everyone knows that. We always say that the cluster A, B, C. But again, there is a problem is that there is a variation. It has not been consistently validated. Why this cluster 1, cluster B, or cluster some traits of cluster B? Then where to classify them? That was the limitations actually. So if you see these features, these are known to you, odd and aloof, dramatic impulse, severity, cluster B, cluster C, anxious, fearful, but this was not validated actually. That was the limitations. So in the categorical model that was used in DSM-5 and ICD-10 is based on the symptoms, and the dimensional model is based on the personality trait. So traits are basically what we have. So even a normal person has a trait, difficulty personality has a trait, even personality difficulty they have, disorder also they have a traits, but how many traits you have and what are the pathological traits you have, that depends where you lie. That is a dimensional thing. So the structure of personality is common to all, but it depends upon the trait, and that influence the radical changes in ICD-11. And they took the decision to paradigm shift from one categorical end to the dimensional model. That we'll talk about. So when the ICD-11 working task group, they were working actually 2010, they had dissatisfied with what the ICD-10 and the DS area A. ICD-11 provides a separate list of explicit emotional, cognitive and behavioral manifestation to help. These three things are very, very important for you. Emotional, cognitive and behavioral manifestation to say what are the level of their dysfunctional manifestation that is given. So ICD-11 has given in 6D10 in the block 1 it is there 174 page number 276. They have given in that draft from actually only 2 or 3 pages are before. Only 5 were there. First is the negative affectivity, that is again 6D11 code number. Disinhibition, anancastia and the borderline specifier was added, borderline pattern. Note, again very, very important, this category should only be used in combination of PD category mild, moderate or severe, or the personality that is difficulty. That is a new term that has come. Some people are not in the disorder, neither they are normal, not in the disorder type. So we come across many people like that. They are the personality difficulty type. That is very, very important that ICD-11 has emphasized and given a means very important to that. So negative affectivity, what is negative affectivity, what is dissociality, what is detachment, these are the actually criteria that is already there. Will not, these are the criteria for detachment. Social to present with patterns of symptoms that correspond to only one or only one PDs. So in alternative model, impairment in personality functioning and pathological personality traits are important. So in DSM-5 actually, it includes following PD: antisocial, avoidant, borderline, narcissistic, obsessive compulsive, schizotypal personality and personality disorder trait specifier. This is a very, very state specified. TS is a very new term and that has been included. When some things are you cannot include, you can always say that it is a personality disorder trait specified, but the trait has to be included here. So here actually those paranoid and your histrionic, these were not included, they can be included here actually. So in the what the general criteria for section 2. So general criteria here is that either moderate or greater impairment in personality, self or interpersonal functioning, that is number 1. Number 2, one or more pathological personality traits. That I said already 5 they have given. So the impairment in personality must be in fact, so these are the same, C, D, it is in adulthood, E, these are the same thing that is there in the section 2 also. So these are the same criteria, but 1 and 2, A or B is very, very important. Pathological trait has to be taken. So now if we see 3 tools in DSM-5, they have paradigm shift. That is, they have completely changed what the concept of PD was there in ICD-10 to ICD-11 from categorical model to dimensional model. That is why nowadays there is no such category like narcissistic personality, histrionic personality like that. You will have to always say the level of functioning and the personality traits, what the personality trait is. So that is the take-home message. We are now heading for a dimensional model of personality disorder, where another term is that according to 11, that is personality difficulty patients can be added there. Personality difficulty, normal personality, personality difficulty, some other people, and at last the personality disorder. But as DSM-5, they have given personality trait specified, TS, that is PD-TS. That is a very, very important thing in clinical practice, because many times we come across many traits, but we cannot classify them whether cluster A or cluster B or cluster C. So there can be, that gives the answer to them. With this I end. Thank you very much.
Very, I think, discuss topic was twice discussed. We have been discussing since long about the categorical classification and alternative classification in so many ways. But when we come in front of the patient, I think I am a fool that I forget everything. Why so? I don't know. All the PG students first join. They take the hand in the hand, ICD 10, ICD 11, this, that. They just go for the psychopathology and categorization. I think we are making things more clumsy, more difficult, and far from clinical experiences and applications. Because we are ready to define our traits and we are ready to define our other categories to specify about personality difficulty and this, that. In long practice, I am telling you, things are so fastly shifting in the same person. Day to day, clear and tidy about his application of DSM-11 and differentiation about personality disorder. I think it is a graveyard for all psychiatrists, personality disorder. कुछ नहीं समझ में आ रहा है तो personality disorder. कुछ नहीं समझ में आ रहा है personality disorder. Change नहीं हो रहा है, trait नहीं पता चल रहा है, मारपीट कर रहा है personality feeling. You can change the scenario, and today's personality disorder may become tomorrow a neurotic by giving.
Sir, I'm regarding, sir, with the category and the categorization and the trait domains. So whenever we make the patient a categorical diagnosis, we treat the category. But if there are more than one traits in a patient, how to treat the patient? Which trait domain should we treat? That is a bit, for me, it's a bit confusion.
One thing is that the management actually, not the treatment, I should say. The term should be how to manage those.
Yes, sir,
patients.
management.
So, as you know, in personality disorder, there is previously as well as today, there is pharmacological management is not at all there, nothing there. But only thing is that the psychological intervention is important to give the insight about it. What are the things what are the traits are prominent in him? How to modulate those traits, that is negative affectivity or antagonism, just give the insight to it, that is very important. And since it is a dimensional model, if we follow the dimensional model, now no one is labeled as such. Previously they were labeled that he is a paranoid. ये तो paranoid personality का ही है, ये तो hysterical है. Now you cannot label that one, that is one good thing. And from management point of view, even in any patient with, that is if you consider PPR that axis 1, axis 2, that is axis diagnosis, if a patient with a one diagnosis has there is personality traits that can be taken care of in the management issues, of course it's a teamwork, not only psychiatrist but with a psychologist and the psychiatric social workers.
So if more than one trait.
I'm very happy. Thanks. सीनियर जूनियर कोई नहीं, सब बराबर है, सब एक ही, सब साथ भी कभी बहुत. We are paying because such a good functioning. So there is no difference. He is only one man.
We must be very thankful to the organizer for organizing such a wonderful academic feast, I should say. Because from the beginning till end, I was there. I was the opening batsman yesterday. Until today, I did not have the courage to go out because I was enjoying all the academic lectures. So everything was well organized. The time and all those is not a problem. If it is the academics, we can always spend time because it was only CME for the postgraduate. So time cannot be a factor. And the other hospitalities are also very good. So we enjoy it, and I hope everyone has taken part in it, everyone participated, and the whole environment of this CIP is really the academics and all those, everything was a very wonderfully arranged. Thank you so much.